do frontal plane 2. Let's go to another schematic and we'll go very slow. If this is becoming quite intuitive for you, roll right ahead, map your ABCs, and see how you do. Raise your hand. For those of you who are still trying to figure out what I'm doing, I'm going to kind of gear it down a little bit. So we have this patient, and let's map our ABCs. First, you want to tell it that you're looking at a AP, and we're interested in the obviously deformed leg on the left. And we're going to choose 100% oversize accept. And now you're ready. Limb alignment, again, click your arrow and hit bilateral and go through your wizard and do your map analysis. Again, when you finish your analysis, zoom in. Just make sure that you agree with your shapes. The center of the femoral head, tip of the troch. Give you a couple more minutes, or about 30 seconds actually, for your analysis. So your analysis, again, just a bunch of points, and then you want to double check them. I warn you that all the red numbers up near the hip, you can essentially ignore. If you did have this person and you were really concerned about the LPFA of 95, then you can take dedicated x-rays at the hip, and that's a whole nother chapter book on hip deformities itself. So let's concentrate in the long bones, so to speak, and down at the ankle. Your analysis should tell you that there's something going on in the tibia, and both the joint orientation lines are abnormal. And so at this point, I would hide your limb alignment lines and concentrate on your tibia and pick your proximal tibial joint line. Remember, in your tibia, the mechanical and the anatomic axis are essentially the same. And again, go to your ankle, pick your joint line, and just like the other example, you'll notice the lines do not cross. So undo your last line, and you have to find your distal axis for your proximal deformity, because there's two deformities and you have to find them. So pick a tibial simple line. And you'll notice, and you can fudge this line a little bit depending on what you think is correct. And I'm going to make this a pure opening wedge osteotomy, again following my transverse correction bisector line, placing it on the fibula. And then again, go to add cora. So underneath your schematic, you hit add cora because you want to find your second deformity, which consists of, again, a proximal and distal axis. Since you already have a midline in the middle of your tibia, right-click that line and say reuse line. And then find your distal axis by scrolling over the ankle and the schematic and hit distal tibial joint line. You can zoom in and see if you agree with your line, where the osteotomy is, and the correction. Once you have this, you can manually correct or auto-correct. Finish and cut. It gives you your segments. You can grab a hold. And then you can grab your distal segment because you want to do it and then you can hide your lines and show your analysis and decide this is what I want to do. I can't see any of the screens when, yes, I think that's, so if you look at the little highlighted numbers, it'll tell you that you've corrected your proximal osteotomy 9.8 degrees. Your distal osteotomy not only corrected 14.9, but you translated 5 millimeters of length with the pure opening wedge. Or I should say it distracted 5.2 millimeters. So you know how much length that you gained on the opening side. Is anybody completely lost? All right, great. Y'all the best class ever. I can tell the other guys. Okay, let's go to the sagittal plane, and let's go to new case. Let's do another schematic because it seems to be a little bit easier just to, and then we'll do kind of a crazy case. Last name sagittal plane. First name 1. Let's try this one. Let me see if this is a good one. Yeah, I think this is good. So let's do, so sagittal plane 1. Go ahead and say it's now lateral. You can make it a right or left, whatever you want to call it. Again, I'm sorry, oversize 100%, accept, and then hit limb alignment. It's going to ask you to flip your image. If your anterior is not pointing to the right, just hit flip left or right. It likes everything pointed to the right. And go ahead and do your analysis. And so it's telling you to place your points, anterior cortex, posterior cortex, again, anterior, posterior, define. Now remember, this is giving you this will give you the distal third anatomic axis. And remember, the distal femoral joint line is the physeal scar. If you don't have a physeal scar, if you look, it's where the little notches of the condyles. You'll see a little contour as the condyle comes around anteriorly and how it hooks around posteriorly in most people. So you finish your analysis. Pretty easy to see on the schematic. And the one thing that this hasn't done that eventually will change, it hasn't given you your map. We kind of went right to the A, right? So your map, your mechanical axis, first you want to draw, you can grab the little tools up on the upper, and you want to center of hip to center of ankle, and it shows you that your mechanical axis is actually anterior to your hinge point, right? Your hinge point's here. And so from a mechanical axis point of view, you would say, this patient's doing pretty good, but they're coming in complaining of knee pain, and their knee looks a little funny. So with this kind of deformity, they'd have a prominent patella. And if you want to do your anterior cortical lines, which will be a little difficult because of this deformity, you might say, well, at the knee, what's going on at the knee? Well, the knee is flexed. So you have a flexed anterior cortical lines. But you have a knee that looks like it's in hyperextension if you have a normal mechanical axis. So this is where the sagittal plane starts getting a little confusing. So you just keep this in mind. What you can do is say, okay, let's measure. You can come up to the angle tool. And these are things that you're doing on your own that TraumaCad maybe someday will tell you to do. But you can see you have an 18-degree anterior cortical line abnormality. You can then just right-click on these little lines that you've created. So remember, we have 18 degrees of flexion. And we have, if you look at the analysis, it's telling us that our distal femur is significantly bowed in recurvatum, 101 degrees. And our patella is flexed with a PPTA of 70 degrees. Ankle's pretty normal, 84 degrees, even though it's red. So at this point, let's find out where our deformities are, hide your joint analysis, and let's go over the femur and use a distofemoral center line. So you should automatically say, why did we use the anatomic distal femur line to do our joint analysis? But in the course, we teach you to do the mechanical line, and it's a theoretical. Well, more than theoretical, it's kind of a methodology. And in the methodology, if you're going to analyze a bone, you need to analyze the entire bone. Does it really matter or not? It can. Now, can you get away with just doing the distal and looking proximally and say, I think we're okay? You can, and this is the other aspect, that you can draw this midline. You see that it's not intersecting at the 1/3, so you know there's a deformity distally. Then you can say, okay, if I drew this line, extend it proximally, it looks pretty good. And if you look at the bow proximally, there's not a significant deformity. Then it might be rotation or something else, but in this analysis, it's okay and you can get away with it. But sometimes it can fool you with some of the crazy cases that we've shown. So at this point, find your distal femoral joint line. And it gives you a PDFA of 83 degrees. And you might decide, well, I want 80. And I'm going to make an 80 PPTA, or you might say you want to make 85. Let's do 80. It gives you an osteotomy. It gives you a hinge point all through the apex. And you might say, that's fine, I like that. Let's go to the tibia, add cora. Again, you might say, I want to do 80. Double click that. Some of this is just being OCD, but it's just, we're playing, so no big deal. And then choose a midline in the tibia. Again, the computer puts the line in a somewhat normal spot, but you have to adjust it until you like it. Now, if you zoom in, it makes your osteotomy right at the apex, but that's obviously unrealistic. So let's come down to a little bit lower. Again, your amount of translation is going to be the distance between these two axes. You want to take your hinge point and put it back where? You're back on your correction bisector line. And you can either do a neutral, closing, opening wedge, whatever you like. I'm making an opening wedge. And now I'm happy. And you can even make the lines disappear if you want, finish and cut, and auto align without lines, and just see what it looks like in kind of your gestalt. And if you see, it looks perfect. Anterior cortical lines are normal. Mechanical axis is fine. Still ahead of the hinge point, which would be right here. And you can then show your cora lines. and show your limb alignment lines. And you can see all is happy in the universe. Those of you who are finished, go ahead and open case 5. So it should be case 5. Does anybody not have a straight leg? Sagittal? So hit on your little new case tab up in the left-hand corner, and let me make sure this is the right case for us. So case number 5 should show us a sagittal, yes. So just select one of these, and then hit next down below the images, because some of these are preloaded, and they've already done the calibration and everything. So it's just a little bit how we loaded the cases in. Again, grab your window to kind of adjust. Yes, case 5. So this is I think this is a young lady. I think this is one of John's patients, Olier's disease. You can see the lesions. And so the first thing you want to do that the TraumaCad doesn't do, but we've taught you, go ahead and grab your line. And you can see this is where it's a typical example of why do we plan with just a distal third? Well, because this is a pretty common x-ray. You can't see the femoral head. And for a Coke or a beverage of your choice, how did they position this patient incorrectly? You know, they did one simple thing wrong. What was that? Externally rotate, they could have done a little bit more, but why are you seeing the other leg? Yeah, because they did one of these, so they have this leg, and the x-ray tech just let them stand like this, and they have to stand like this. If you just simply pivot like you're doing a basketball pivot, and you'll see the entire leg, very, very easy. And so, so whoever got the right answer, tonight, I don't know. There'll be a bar, should be at the case presentation, so let me know. We'll have a round for everybody. But so if you take your line, let's just guesstimate the head's probably right here, and just for giggles, you do your axis, and you can see that you have a flexion deformity. You're behind. You can kind of see that already, but if you wanted to be quantitative and you from the hinge point over, you can measure your MAD. The other thing is you want to measure your anterior cortical lines, because that's really important, as we talked about, how to analyze what's coming from the bone, what's coming from the soft tissues, no surprises. So you measure this. Again, just use the simple tools at the top that are still available for you. You can use those at any time in any of the images, no matter what procedure you have selected. And you can see we have a 20-degree fixed flexion deformity of the knee, and let's see if we can figure out where that's coming from. So now let's start the analysis. Do your map and choose your bone. So limb alignment analysis. Again, it's going to ask you, make sure you're pointed to the right. Hit OK and start your, whoop, I flipped it. I'm sorry, I got to go back. So you should hit OK. I flipped. So if you flipped it, just unflip it and do your analysis. And you can see this is the real world. You'll come down and say, okay, where is this physeal scar? You'll see that the condyles aren't completely overlapped, but you see a little bit of a physis here. And you come back and you'll see something that looks like a physis back here. And then we'll zoom in a little while and see if we're right. Your tibia, if you look, you have tibial spines, but this is actually a pretty good x-ray to find. And then if you look at the ankle, the medial malleolus is a little bit rotated. You come to the sclerotic anterior border. And some of these, when you do in the old courses, we would have all paper dolls, and it's like you put it here and here, and then you go home, like, where do you put it? Some of it's a gestalt, it's kind of a feel, and that's where the art comes in. And so you get your analysis and you see a bunch of red numbers. Again, zoom in and make sure you like your line. And it won't be the first time or the last time that I've taken an x-ray like this and then gone back to the x-ray room and did it again, right? So that's not a failure either. But let's just run with what we have. Again, now you might decide, or I have analysis and I know there's something deformed, and I'm kind of worried because there is a bow in the femur. You can simply extend this line. Actually, better yet, grab another line and just make it on top of this line, parallel, and then measure your anterior bow. And this is all being obsessive compulsive, but if you know, this is the real world, you're going to say, okay, can I accept this anterior bow? Because my PDFA is 74 degrees, it's flexion. Is there a significant contribution? What just happened? Grabbed the wrong line. And just eyeballing it, it's going to be normal, but being OCD, I'm going to measure it. And we have an anterior bow of about 15 degrees. That's fine. All right. Obviously, if you're going to do a retrograde nailing, you might deal with that also, and you might do a double osteotomy and get rid of that. So let's go ahead and let's find your apices. And if you look, I'm adjusting my tibial line because I don't quite like it. And I find that I think it was like 78. This is normal. It might be out. So your tibia is normal, but it looks like there's an obvious deformity distally. And that's like, you're talking, I don't know why this little number we can't see. Oh, here it's 76 to 80. No ankle pain, not a problem. These two deformities have compensated for each other. Now, if the patient's presented because they don't like the appearance of their distal tibia, they have a deformity and their foot's hitting different, then you might decide that is something that we have to do. But let's concentrate on the femur and find the apex of deformity. So now you're into the ABCs. You're going to use a mid-diaphyseal line distally. I like that. You want to use distal femoral joint line. Again, it gives you, this little number gives you the amount of deformity, 9 degrees, and it shows you that you're creating a 83 posterior distal femoral angle. If you look, it gives you your osteotomy site, again, at the apex. For a fixator-assisted plating, I think this is very doable. And do a neutral wedge, put it right at the apex. And then when you're ready and you have your apex and you put your osteotomy where you would like it, you can finish and cut, auto align, and you have a nice straight leg. You can then look like your anterior cortical lines, pretty well collinear. There's going to be a little bit of hyperextension just because of this S shape. If you really feel wild, you can do double osteotomy in the tibia and correct that if you think that that's a problem. You can also grab your line again and you can pretend you can see the femoral head, draw down to the ankle and say, hey, I'm just at my hinge point. I'm still kind of worried, so I'm going to correct her a little bit more into extension and make sure that she can lock her knee during gait. The other thing you can do, what's nice, is intentionally mess up and see what happens. And this is a great educational tool for residents as you go back and decide, okay, undo cut. Let's take our our little hinge point and put it up here, and what happens? You know, finish and cut, auto align. Oh, I'm sorry, auto align won't let you mess up. Undo cut, finish and cut, you have to grab your segment and you rotate and say, okay, if I want to do this, this is what's going to happen. And you can see as you rotate farther, you're getting the translation that we talked about.